let me just mention another person who I think is important to, whose contributions are important to social science in general, and particularly the study of narrative. And I'm pretty sure he was mentioned prominently in the Reisman article yesterday. His name is Elliot Mishler, and he's some of you are nodding your heads, he's pretty famous. He's a social psychologist, and again, in that mid-'80s period that I talked about a lot yesterday, he was even a little earlier. I looked it up last night. It was 1984, and he wrote a book called The Discourse of Medicine. And the discourse is really the discourses of medicine. What he was looking at was, and he does a lot of kind of very fine linguistic analysis in some of his work, and he was looking at how patients and doctors talk and why there's often problems, and he came up with this concept of the voice of medicine and the voice of the life world, and how different they are in character, which then it's not surprising that doctors and patients sometimes have trouble talking with one another. And really, I think several people are alluding to this. I'm going to go back to Arthur Kleinman, who in his way talks about that same difference. And I think you saw in the Hate It Paternity article for today, the when they were talking about taking a history. That definitely is the voice of medicine, and patients have trouble fitting into that mold. And they really shouldn't. They're the voice of the life world. So I wanted to mention Mishler in that way, and then he comes up again with another book he wrote in the early 90s called, but anyhow, it's research interviewing, and yeah, I guess it was more like late 80s. And this is a book that is cited a lot and referred to a lot, and he comes up with what we would, I think, now think of as, well, yes, of course, but at that time it wasn't yes, of course, which is that the researcher is part of that interview situation, and how it comes out isn't just based on what your interviewee is telling you. It's how you are asking questions and how you respond to questions, and whether you interrupt your interviewee, whether you change topics. All of that goes into shaping the meaning of that conversation between the interviewer and interviewee. And prior to Mishler writing that, it was kind of assumed that the research interviewer was kind of this, I don't know, totally objective, standing kind of outside the interview, asking standardized or semi-standardized kinds of questions, and really it was all about what the answers that the interviewee gave, without seeing that it was really a holistic interaction. And that's what he pointed out, and that was a very important insight that people just didn't have up to that time. I was gonna, I don't know, maybe you have to be there to get the humor of this, but in working with Paul Hated on those patient interview transcripts, we look at the transcripts and we'd see really clear instances where one of us or whoever was interviewing inadvertently just kind of cut into the interviewee's responses, or got the interview on a whole other track, when maybe that patient was about to tell us something important and we cut it off. So when we were coding those interview transcripts, the code for that was the Mishler code, that we Mishlered somebody by cutting them off. Okay. So I'll refer to him a couple times today. So these are the kinds of things that are at stake between patient and doctor when they talk to each other. Of course, an exchange of information, trying to solve problems, and first of all, identify and define those problems. I don't know about the healthcare system here in Singapore, but it's a pretty complicated one in the US, complicated by, specialty care and levels of hospitals and insurance plans and all kinds of things. So feeling like your provider is your advocate is important. That you don't have to love your doctor, but you need to have a functional relationship with your providers. Outcomes that are satisfactory to both parties, and hopefully getting cured, but that's not always possible, but you at least want to feel cared for. So what gets in the way? And here is where we start getting into the voice of the life world and versus the voice of medicine. So for patients, at least in the US system, there are often long waits. Even when you have an appointment, you arrive on time, but you might still sit in the waiting room for a half hour or an hour. And then when you get in to see the doctor, you feel like, oh, that person is so busy, we have to kind of get through this in a hurry. The average appointment, again, average, this really varies, is around 18 minutes. The feeling that doctors don't speak plain English, they don't speak in plain language that's easily understandable. They may not explain things very well. Sometimes patients feel like they're really not treated as a complete human being. Not all the time, of course, but sometimes doctors don't take my opinions into consideration. Lately, this probably wasn't the case decades ago where doctors made all the decisions for patients, but now since there's an awareness that patients have a stake in their own health care, it sometimes goes to the other extreme, where instead of there really being collaborative decision making, it's like, okay, here are your choices. You decide what you want to do, and patients don't always feel adequate to do that. And then in our system, constraints with the payment systems, managed care, which means you're in a certain health plan, and to go outside that health plan may not be possible or may be a big hassle. Oops. From the doctor's point of view, and I mentioned this the other day when I gave the talk, patients are disorganized, which means they're not maybe fitting into the time slot that the doctor feels is available, and they don't follow that heuristic that Paul Hayden talked about. There's certain things that doctors are looking for that they're taught to do. What's the current complaint? What's the history of that complaint within certain boundaries? If patients aren't presenting, which often they're not, in that kind of heuristic form, then they get labeled as unreliable historians. which doesn't mean, and I think you brought it up the other day, they definitely have a history, but it's not the same history as the doctor is looking for in that format. Patients may not be compliant with what doctors have suggested to do. This is a constraint of the system. The doctors get reimbursed by their insurance company or by their healthcare organization much more for doing procedures than for sitting there talking to patients. So they don't have great incentive to do that communication bit. Litigation, possible litigation. So there's the practice of defensive medicine to cover your behind so you don't get sued. A big feeling of providers in the American system is that they've lost autonomy. There's not a whole lot of doctors who are out there in single practices anymore, so they work within the constraints of a managed care system with lots of rules and times that are set up for them, and it may not be the way they want to practice medicine. Lots of paperwork, and most recently electronic medical records, which in theory should make things easier, but in practice, from what I'm hearing from the physicians, it is actually more time consuming for them. And then stress and burnout. So here are some of the topics that are, and there's many more of course, but some of the things that people who study patient-doctor communication, who focus on that, are interested in. Okay. So,
could you elaborate on what you mean by health disparities?
Yes. Oh, yeah. That's not a term that's used. Okay, so health disparities mean that the health outcomes, I'm glad you asked that. The health outcomes, well, it could be health outcomes that people do better and worse. It could also be a disparity in even accessing health care, and these are often along the lines of race, ethnicity, socioeconomic class, gender, and one of the projects I worked on had to do with access to healthy foods in rural areas where there's much less choice. So even geographic positioning could be a cause of disparity. I just saw yesterday online in the news a new study about women's health in the US, and it was shocking to me. I should have copied it and brought it in, maybe I'll do that tomorrow, where early mortality rates for women in the US are shockingly on the rise. And the headline was women dying before their mothers. So younger women are not doing well on a health basis, and I had no idea about that. That was really surprising to me. That would be a very good example of a disparity where women in the society are dying much earlier than men, or the women that came before them. Is there anything else on there that I should? Racial ethnic concordance. This is kind of a concept in doctor-patient communication where the communication, the studies that have been done on that show that when the provider and the patient are from the same racial and or ethnic groups, that the communication goes much better, which I guess shouldn't be surprising. But like in the US context, we don't have enough African American doctors to go around for the African American population. so that concordance isn't always possible. But we know that things work better like that. Divided loyalties. With the advent of managed care and doctors working for these large corporate healthcare systems, sometimes the rules of that system interfere with the way they'd like to practice medicine and what they feel is best for their patients. So for example, their healthcare system often has a drug formulary, and certain drugs they can prescribe within that system and patients are able to access, but they may feel that a drug outside that formulary would be much better for their patient's health, but they're not allowed to do it because they have to work within that system. So that's what I mean about divided loyalties.
Right, so connected to this, I was actually looking for something that's not apparently in your list, which is when patients, for example, are much more into naturopathy or homeopathy, and then the doctors always want to push the aggressive drug-taking route.
Yes.
And those kinds of conflicts that arise between patients and doctors.
Yeah, so I talked about that a little bit on Friday when I talked about integrative medicine, but and it was the case both in Singapore and the US. So patients go on their own for what they consider natural remedies or homeopathic, because you can, at least in the US, buy that without a prescription over the counter. So patients are doing a lot of that for themselves, and they don't communicate that to their doctors. And in Singapore, it's definitely with traditional Chinese medicine, or a subset of the population, it may be Ayurvedic kinds of healing, but they're not telling their Western trained doctors that they're doing that. And yes, that's a problem. I mean, in some cases, the Western medicine that they're taking and the alternative medicine may not, go together well, but nobody knows that they're doing both those things. And in a way, this is a much bigger category, but I'd sort of fit that under cultural competency, that we're trying to teach cultural competency to our healthcare professionals, and one aspect of that would be to try and understand the culture that the patient is coming from and what the common ways of treating somebody for a certain ailment in that culture, or simply to ask the question, and we try and train doctors to ask this question, they most often don't. What are you doing for yourself to help with this problem? If they just ask that question, they don't have to be knowledgeable about everything in traditional Chinese medicine, although in a population like Singapore that would help, but at least to ask that question so the patient knows it's okay to talk about that, and so the doctor is informed. Okay. So where the power lies in the doctor-patient situation, there's different models for how this works. The classic medical model is the doctor's in charge, the patient is passive recipient. So I talked the other day about Gina, the woman with diabetes, and that she was trying to be a more active patient. I didn't really talk about that on Friday. I talked about integrative medicine, but there were students there from the econ department. I'm not really sure why they came, but they were there. And so at the end, one of those students, and I think she had come from mainland China, and she said, why would somebody want to be an active patient? I want to go to the doctor and the doctor knows everything. I want him to decide. I just want him to take care of me and tell me what to do. And so, you know, that's her prerogative. And I don't know if that's the way things typically go in mainland China, but that was, and she was pretty young. So that would be an example of the classical medical model. A more consumerist model goes in the other direction. The patient feels like I'm paying this doctor as kind of my employee. I'm in charge, and that provider is there to supply information and services to me. And then this collaborative model where there's a more egalitarian kind of relationship that, I mean, my bias is in this direction because I feel like if the patient doesn't speak up, the doctor can prescribe medication, can make lifestyle suggestions for changing, but it's the patient that has to enact that, and they also know what their life situation is, what might interfere with some of those instructions. So if the patient isn't ready to contribute that information, I feel like the problem solving often doesn't work. But nonetheless, you know, if someone wants to go with the classical medical model, that is their prerogative. So for doctors are aware of this, and it's a hard job to kind of figure out where is this patient at in terms of their attitude, and can I shift my style around to match the patient's style. So I have empathy for the doctors because that isn't easy. I think that just by, I think the internet has made a huge difference in how people deal with their own health care. I mean, there's information seeking of all kinds that is so available to many people now, and I'm not saying everybody utilizes this, but a lot of people do. And even 10 years ago, people wouldn't have been able to get the information that's available now just by Googling on the internet, and then other forms of media that have been around for a while. So I don't know, on like your local news here, is there usually a health segment?
Yes, there's a supplement on Wednesdays or Thursdays called Mind Your Body, which has lots of health-related information, interviews with doctors, patient letters consulting about different conditions, and then they have a section where they consult, for the same letter, they consult both a Western doctor and a traditional Chinese medicine practitioner.
Oh, I would love to see that. I am very limited in my hotel as to what.
It's Wednesday.
The Straits Times, so I think it's Wednesday or Thursday that has the Mind Your
Oh,
Body
in the
supplement.
newspaper.
Yeah.
Oh, that I can get.
Yeah.
On our local, both national, but a lot on the local TV, there are health segments almost every day, making people aware of diseases, of resources where they can go. On our local radio stations, I mean, health information and medical information is ubiquitous, it's everywhere. I'll have to look at the Straits Times. Thursdays?
Maybe today.
It's Wednesdays.
Today? Oh, it's
Wednesdays.
today's. Okay.
It's
Thursdays-
today's,
Thursdays
okay,
is
great,
fashion.
okay.
Yeah, urban.
And talked a little bit last week about
That's right.
there are actually being programs to train people to ask questions. And that might seem kind of elementary, but people get really kind of cowed when sometimes when they go into the doctor's office, they realize there's limited time, or they may feel like their questions don't have merit. People just don't speak up for themselves. So there's actual programs available to help people become more active, question question askers, because that's really important. As chronic disease becomes more prevalent, and it's already very prevalent, people are living longer, but they're living longer with chronic diseases, then more of the management falls onto the individual. I mean, doctors can't take care of everything. It's not in the hospital, it's not under their control. They can make suggestions, but then patients have to enact that. Seeking second opinions, referrals to other kinds of experts, either Western medicine or not. And then we see health activism much more on the rise. I think this started with the women's movement, probably in the 1970s, with the AIDS activists in the 80s, and now all kinds of groups are out there in the public sphere on their own behalf. Okay, we talked about Walter Fisher yesterday as humans as storytellers. We've talked about these different aspects of narrative, and we talked about the functions of narrative. So I'm going through this pretty quickly. Those who weren't around for the other two sessions, this is in the slides, but I'm not going to spend time on it because we've talked about it a lot. Rita Sharon, who I talked about yesterday, who trains her medical students and residents to do close readings of patient stories and to try and think empathically in terms of the patient's point of view with her parallel charts. Medicine practice with the narrative competence to recognize, absorb, interpret, and be moved by patients' stories of illness. My friend Paul Haydett, who you read today, not in that article, but in one that you'll read later, came up with this kind of interesting concept that he calls a narrative jolt. So he's talking about doctors being in their biomedical mold and doing the kinds of histories that they're taught to do. But if they're really listening and the patient tells, and the doctor allows that to happen, for the patient to tell a story, there will be something in that story that will jolt a doctor out of their medical regimen if they're doing what Rita Sharon says and really listening, and then bringing it down to a less biomedical and a more common human interaction. So then we get to the notion of co-constructing a coherent healing narrative that both people are contributing to. So this slide comes from Arthur Kleinman's way of conceptualizing, and again, I think it's another way of talking about the voice of the life world and the voice of medicine. Doctors tell stories of disease, and by disease, he means where there's a set of symptoms, and usually they are verifiable in some way. So we go have a lab test done, and they're looking at what's in our blood or in our urine, or we may have an X-ray or an MRI, but they're looking for some way to confirm what they think might be wrong with the patient. And when a patient has something that's not confirmable that way, like chronic fatigue syndrome or fibromyalgia or some of these other things that for doctors seem kind of vague, and some doctors are actually doubtful that the patient is really suffering the way the patient feels that they're suffering because they can't confirm it in an observable or measurable kind of way. But that's the way they're trained. Patients tell stories of illness, And in common language, we might use disease and illness as interchangeable, but in Kleinman's nomenclature, they're different things. So illness is the experience of feeling not well. It's whatever we experience, and we're not aware of whether, there's too many white blood cells on an analysis, or if there's some kind of obstruction in your bowel that you can see on x-ray, but you're not feeling well, whether it's verifiable or not. And those two ideas sometimes go past one another. Each person incorporates either implicitly or explicitly an explanatory model. And I think I mentioned this briefly last week when I talked about Gina, but the explanatory model, and Kleinman has 8 questions that he uses to elicit an explanatory model. And they're pretty simple questions, but it's like, what do you think is wrong? What do you think is wrong? What do you think could help what's wrong? How do you think this is going to progress? How is this affecting your everyday life? Questions like that. And it's either the provider's or patient's way of explaining whatever the problem that the patient has come in with. Now, doctors don't think they're telling an explanatory model. They think that they're saying precisely what's wrong. But, and sometimes they are. But nonetheless, it's a way of explaining that they're trained to do. So I'm really curious to read the Straits Times, because I would think that a traditional Chinese doctor's explanatory model of what's wrong with a patient might sound very different than a biomedical doctor's explanation. And they're both highly trained, but they have different kind of categories in their heads. And then the patient themselves may have a third way of explaining what's wrong. So the problem in communication comes either when those explanatory models aren't made explicitly, so that each person is operating under a different explanatory model in their heads, but they haven't really stated it out loud. Or sometimes the patient does try and state their explanatory model and isn't listened to very well, or even worse, the doctor may not acknowledge it well or make them feel like this is a legitimate way of talking about whatever the problem is. So Kleinman says it's really important that you make those explanatory models explicit, that you get them out on the table, and at least that way you can see what the differences are between what the patient is thinking, what the doctor is thinking, and some of that may need to be negotiated. So if the patient wants to do something for themselves that isn't usually sanctioned by the doctor may need to negotiate and make in order for the patient to feel legitimized and to want to continue seeing that practitioner. Behind those explanatory models are values and priorities that may be quite different. And then there are styles of telling each story. And as we talked about yesterday, doctors tend to be more in an accounting kind of mode of telling. They're giving the official explanation from a medical point of view of what they think is wrong. Patients tend to recount. And this is why doctors get impatient with their style of history taking, because they may bring up a lot of stories, they may reach far back in their memories in order to recount what they think has happened that has led up to the current problem. And so those styles of telling may be very different. And then what you read today, the notion of building a history together, co-constructing, rather than simply doctor active, patient passive, swooping in and taking that history from the patient. Kleinman, and then we're going to be reading Arthur Frank as well, put big emphasis on listening with the intent of really taking in and witnessing patient suffering, to really understand that. And that's very different than critical listening, where we're listening for certain things, we discard certain things if they don't fit with what our focus is. And we know from, I think, being academics, we're very good at critical listening. That's what we've been trained to do. And that's, so yeah, and doctors are as well. So to get out of that mode and really be in empathic listening takes effort. You'll see a lot of the second point in Arthur Frank's work, appreciating embodiment in storytelling. That bodies themselves are text to be read. And this includes nonverbal communication that goes along with verbal communication. I've referred several times to Mattingly's notion of reemplotment and figuring out what story you're in when something ruptures your life, and that's often the case in a medical context with not feeling well. And then these things get written down in the chart. And you don't get to see your chart as a patient, right? But it's there, and all the providers who attend to you, they're reading it and they're writing in it. And you'd be surprised what they're writing about you. So the patient's voice in the chart is totally missing, but all the things that have been written about them over whatever the history is there and gets reified in terms of who you are as a person for the next provider who sees you. That chart follows you around. I think this assumption about health and healing is a larger notion. Doctors are trained to think about pathology and what's wrong with you, and getting the larger context of who you are as a person in the context of your whole life, and the fact that you might be having this particular problem, but it's certainly not the only thing going on in your life, and getting that fuller context is more an attitude of thinking about health and healing rather than just fixing a problem. Taking into account environmental, familial, cultural, financial. So yesterday when I mentioned trying to teach doctors a biopsychosocial, and some people would add spiritual, way of thinking to the regular biomedical kind of focus is a big leap. Because it's hard for them to encompass all of that in their thinking. And so what are the best possible outcomes given the circumstances? You have to, the provider needs to understand what those circumstances are. So that's kind of in a nutshell, a lot of ideas. And what I would like for us to do, by the way, when we segue into the second half of this, and we're talking about research interviewing, I'm not saying doctors' jobs and your jobs as researchers are the same thing by a long shot, but I do think there's a certain analogy that as researchers, we're kind of sometimes stuck on critical thinking, that we have particular focuses, that we have an interview schedule that we think we need to accomplish, and that may be very different than what's going on with your interviewees and participants in the field that you encounter. So it may seem kind of distant to you, but I think some of what we're talking about with provider-patient communication can be analogized with some of the problems we run into with research interviewing. So what I would like to do is to show you a tape that was made a while ago, and this was as part of training residents to be better communicators. We videotape them with patients, and then we go over, we do videotape review with the residents. So the doctor you're gonna see is a fourth-year resident, so he's almost ready to graduate, be a full-fledged doctor, licensed doctor. And this is one of his patients that he's seen several times before in the family practice clinic. Now, I'm a little nervous about showing you this tape because it's going to be hard for you to just understand the patient, not because of what he's saying, but how he's saying it. The patient is an African American patient. This was done in Chicago when I lived in Chicago. The patient came from Mississippi, which is one of the most southern states in the United States. And there's a very particular kind of accent that comes from living in the Deep South, and particularly among an African American population. So when I've shown this tape before, even for classes in the US, people have a hard time, if they're from the North in the US, understanding the patient, both because of his accent, but there's also particular things that he says. For example, he'll ask the doctor, I'll give this one away, what makes a person so greedy? And that has a particular meaning for that patient. It's really in the context of his diet, because the doctor is, as you'll see, telling him to lose weight, and he probably has a big appetite. And so that's his way of phrasing that, what makes a person so greedy, to his doctor. So there's little things like that. If you want us to stop the we can do that on here, right? If there's something that you hear that you'd like to hear again because you're not getting it, or I may be able to translate just because I've heard this tape many times, just raise your hand and say that, because I am a little afraid this is going to be difficult for you to understand. Here's what I'd like you to do. We're going to watch the first 15 minutes of the interview, because this was done in a training environment. They went way over 18 minutes because the students are allowed to take more time. So we're going to cut it off at the point where the doctor does the physical exam. We're just going to hear the first part, and that takes about 15, maybe 20 minutes. What I'd like you to do, and I'm going to have to tell you what happens at the very end, because this goes on for some time and we probably can't reach the end of the interview quickly. But I'm just going to divide the table in half. Let's starting with Mary and over. And this half of the table, your job at the end is to say, how would the doctor give a summary of what happened with this patient to their attending physician or to a fellow resident? What would the resident say about this interview? On this side of the room, your job is to, the patient tells us that he has an adult son living with him at home. Your job is to summarize how would the patient tell his son or maybe a neighbor what happened when he went to the doctor today. Okay? So you're doing the patient's story, you're doing the doctor's story. And with that, we'll start.
You know, going far.
Good for you. Okay, let's talk about you now. How are you feeling?
Well, you know, I feel pretty good. Just, I feel sort of a little bit nervy still. I just have these little boots on. You feel like they weigh 200 pounds.
This is 200 pounds.
Yeah, my legs, they feel so stiff, you know.
Well, you know what I want to hit you with right off the bat is the fact that maybe they don't weigh 200 pounds each, but you did gain 17 pounds on me
since the last time. I went back up.
You impressed me. I was real impressed.
Yeah.
By your weight loss.
Well, I guess I second round eating because wasn't getting out like then exercise,
hibernating,
whatnot. See, I figure that. You know, I feel it too.
Yeah.
Yeah, I feel it. I believe that. You're right. Oh, and right now I'm hungry. I didn't eat nothing this month. I'm just starting to feel like.
Just so see if you can get the scale down or something.
I don't know.
Okay. Well, yeah, that's a real concern of mine. Now, we've talked before about your weight having a lot to do with your stiffness and your aches.
And I really do believe something. I believe that is a portion of it, you know.
Part of it, right. Yeah, I'm not saying it's all of it.
No. I have, I don't know what.
Well, the other part probably is the fact that you had surgery back there, okay? And the surgery, whenever you start fooling around with the bones and the joints, it's just like if you're in high school football, if you get an injury to your neck or your shoulder, it always seems to act up later on in the winter, so, and in the humid weather. So the weight is one part of it, and that's the only part that we can change, because the other part we can't change.
No.
You know, the arthritis in your back.
You know, it had to come, and it come self-naturally,
Right.
or something like that. You know, I believe that.
Okay. So now, where did we go wrong? You just felt like it's getting cold, and you just started hanging out in the house.
Oh yeah, I haven't been, exercising like I've been out,
Yeah.
and walked a couple of times around the block, and I was feeling pretty good. And I lose that weight, I can tell the difference in a few pounds.
Yeah, I'm telling you.
By moving, how I feel when I move,
What are you going to do, huh? Now, that's the big issue with you. As I look at your chart, essentially, that's the big thing that we need to work on. Now, you started that diet. I'd like you to try to, the reason I wrote in my note that you lost 14 pounds because of starting this new diet that we put you on. If you could go back to that diet, it seems like it worked.
Yes. I have to. I have no other choice. But, what this person being so greedy? I know I got to eat if I take this medicine.
What makes a person so greedy?
Being so greedy.
Ah.
It just have that hungry something. I don't know.
Yeah.
you know, but,
I don't know.
ain't as bad for the weight of people I have seen, you know, a lot of people, you know, but,
I don't know that it's greedy. Maybe we could use another word. What makes people have to continually feel like they have to eat? Maybe it's not greedy. I understand what you're saying. Different people for different reasons. Some people have too many things going on in their life. Some people, you know, and they eat.
You know, I think all about those things about a person getting a little mental about something, you know,
A little
words
mental.
or something like that about things, you know. I think about it, you know, and I ask myself sometimes, I say, well, you ain't slipping, you ain't getting crazy, you know.
No, I don't think you're crazy.
No, but you know, just like people's talk or people's, you know, minute a person, if you walk out in front of a car or something like that, first thing you want to ask, would they worry about anything, you know, or something like that, you know, stuff like that.
Well, what do you do? What's going on at home? Are you by yourself?
Yes.
You got some friends?
I mean, I'm not by myself. But,
You don't live alone?
No, my son lives there.
He lives with you?
And with my wife,
Okay.
she helped me, you know, after she passed.
When did she pass?
She passed about 2 months ago now.
No, I didn't know
She's
that.
in this hospital. Yeah.
Oh, I'm sorry.
Mm-hmm.
I'm sorry.
And so she got sick unusually, you know. She never did give up on nothing. And didn't give a complaint to nobody, you know. Now, she was sick when I came in the hospital for surgery, I guess, you know. Yeah, but I couldn't tell it, and I asked her at the time, I said, what is it? I said, what is your complaint? You had complaints and you don't say nothing, tell me nothing about it. I knew the doctor asked her out here, he asked her, you know, when the last time she had an x-ray, see. And the woman, man, she hadn't had an x-ray for a long time.
Yeah.
And he told us that she should have kept that up, see. Because she came out here and she had a
lump?
Yeah.
In her breast?
And she ain't come back no more for x-ray and all that stuff, you know.
Yeah.
And he told us that you're supposed to continue to clinic
Sure.
and take this x-ray, notice yourself, see. And find a, you know, that.
So you tried to help her. You tried to remind her to go, but she just...
Well, I was, you know, in fact, then she had got sick then, see.
Yeah.
Then I asked about, had she been, you know, in a bad way, you know, and then come to the doctor, scared, go to the doctor. She wouldn't go to the doctor. She'd go to church, though. She never missed going to church. I see her felt so bad, and she'd go there and read the Bible and go in the room there and come out dressed. Better go to church. Yeah. I said, oh, boy.
Are you a church goer, or have you been going since your wife died?
Yes. Yes, I went to this last weather got so cold.
Yeah, sure, sure.
I went time, I ain't went down a couple Sundays, see.
Yeah,
Church.
yeah. Have you been finding that the people there are able to help you out when, you know, do they know that your wife died and they kind of...
Oh, yeah.
The funeral was at the church?
People.
It is?
Ooh,
Okay.
Ooh, she's, everybody knows her.
Everybody knows her. What about you? Do they know you?
She's what you call it, in church she was a...
Deaconess?
No, not a deacon. What you call the other one is,
an elder? A deaconess?
I'm trying to think of, oh, geez, no, I can't call it. But anyway, she was the president of Portion Church, you know.
Okay.
And everybody knows she come out the hospital and visit people and all that stuff, you know. She had permit, you know.
Yeah.
Missionary.
Yeah.
She was a missionary.
Missionary. Wow.
Yeah.
So how have you been able to sleep well?
No.
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 Since she died?
And not even before she died.
Before she died.
I mean, as I said, my problem was, you know, funny thing, I can lay down and I can go to sleep, but I wake up and I wake up aching. My legs and everything aching for me. From here on down. you know. I tried to stay with it, you know, anyway. I said, for sleep, I always was a sleepy head person. I slept, go to bed early, you know. And so, yeah, and now, every time I lay down about 5 minutes, I'm going to sleep. But when I wake up, boy, I be aching. And I turn over from side to side, you know. Maybe this side, maybe to stop and turn to the next side, you know, and get it that way. Now, really, I changed. I went and got a mattress from a bed, and you know, that mattress ain't 2 years old. And that mattress, I'm telling you, about me being weight, I guess, paid just about I paid $180 some dollars for that mattress, you know.
That's a lot.
And I didn't even know now, you know. Now I can't touch, for my feet, I can't even touch metal with my feet. I get in bad trouble.
You can't touch metal with your feet.
No, and I can touch it with my feet, ooh, man. Look at it, bite.
Cold.
Yeah, shocky.
Shocky.
Yeah, bite, like, you know. Ooh, I get them off of that, you know. I don't know what, and I can't stand wool either. I got these wool paints on there, and this some would help make me ache right now. That's what I've got to get out of this stuff. Get chitin. Gotta find get
Yeah, I see them. Underneath your pants, you have wool pants on, right?
Yeah.
Sure, yeah. Well, they can itch sometimes.
Yeah, but I can't stand to touch no kind of metal from here down.
On the right side only?
Both sides.
Both sides. And that's been since your operation?
Yeah, I couldn't even put, when I was in the hospital here, I couldn't put the wool blanket on my bed. They had to roll up, and I let it stay rolled up down to put it bed.
Yeah. You know, sometimes that can happen from the, I don't know if the neurosurgeons have spoken to you about this, but sometimes that can happen as a result of the operation. You can get what we call
That's electricity or something like that.
Yeah, well, you know what, they operated around your nerves, you know, and the nerves were not cut upon, but maybe irritated, and there's inflammation in the area, and, you know, it can cause funny feelings in your legs like that. But do they know that, I'm sure they've known about it.
No, since I've been...
They might not have been able to do anything, they might not.
When I've been coming back for treatment, do you know I haven't mentioned that part. One thing I say, I'm stiff, and it swell. My legs, you know, I told you about my legs swell. Sure. And like that, you know. But I never mentioned about it. I was being intended to, but somehow, I never said that. The one that if some of this could have came by the operation, you know. You know, I mean, see, I was on the machines, what you call them, and them stuff was giving me fits in the bed here. You know? The TENS treatment? I was so glad when I took that stuff off of me.
I'm not sure which treatment that you had.
Them machines that they can look at and tell if we're moving or if anything functioning in the hospital, you know. Okay. They got them on horse auto machines like that. They hook you up, you know.
And they cause your muscles to move?
Yeah, and I could tell the difference in that electricity too. I big Macy even time.
Yeah.
Hey, you take this off. Be still and don't move. I just cranks and say they'll come loose, you know, because it just sticks them on you, you know. And the machine stop working every time you hear you get noise, you know.
Okay. Kind of a monitor.
Yeah. I like electricity. I just tell you.
Why don't we take a look at you a little bit, okay?
Yeah, okay.
And why don't you have a seat up here and take your shirt off, and I'll just take your blood pressure and take it.
Yeah, okay.
And then I'll take your shoes off because I want to check your. All right. You made it?
Let's see. You want okay or just out?
Well, actually, just this sweater, and then maybe we can roll up the.
More is good.
Okay, let's.
Yeah.
So the doctor knows he's being recorded,
Oh, absolutely.
but not the
This is
patient?
for their, yes. Everybody has to give consent.
So the patient knows as well?
Yes.
How long was that video?
How long ago?
No, I mean, how long the video?
Oh, it probably goes for about 40 minutes. because there's a part after he does the physical
Oh.
examination. There is other good stuff on here. I don't know.
Looks like about 30 minutes.
This one was,
Can you fast forward and see if you can get past the physical
It's
exam?
about 15 minutes.
If you can do
15.
that, we'll play the ending.
Just now, so it's 15 minutes.
okay.
And would you,
I was thinking that it's already a little bit long for the normal.
But this is a training, this is to train the residents, so
I see, okay.
it's different. Yeah,
Mhm.
I'm sorry, Sam.
would you say that the pace and tone of the consultation was influenced by the fact that it was being recorded?
No.
So the doctor wasn't.
They do this several times. This is part of their residency training.
It seems he seems very patient.
Yeah.
You're asking him a lot of questions about his
Right.
life.
He's a
and
nice
his
guy.
wife.
It's counseling, right?
Yeah.
Okay, well, he's,
We are very
I
skeptical
think
with
the
this.
resident is a nice guy, but
Right.
also he's been taught about biopsychosocial, so I think he's really trying to do that. But why don't you guys have a quick consult with each other, and then I want to hear what the doctor's story is, what the patient's story is. So put your heads together quickly.
Yeah, sorry.
Over this wife, the wife's death and stuff, it sometimes can be difficult, okay?
That's really,
Are you using I'm sorry? Are you using the collace?
what, the what?
Collace.
Yeah, sure.
How many times a day are you using it?
3 times.
I think we can cut it.
3 times a day.
Okay, let's try and put into application some of the concepts that I just talked about. What are the explanatory models that each of these people are using?
I think the doctor is operating under,
He's accounting.
yeah,
He's
Or
what?
He's trying to account for his weight gain
Yes.
and all the stiffness and all the symptoms.
Mhm.
And the patient is just trying to recount what's been happening the last 2 months.
Okay, so there's definitely different styles, as nice as the doctor is. Yeah. But that doesn't quite answer the question of what's the operant explanatory models.
The doctor goes by like the psychological way, like make you try, I don't know, he's so understanding.
Well, we taught him behavioral science well, so good.
But really, like here's my number, call me anytime. Wow. But no, what a good doctor he is.
Well, this was a number of years ago. I have doctors now that I can email, I can send messages to, and they'll reply. Not every one of my doctors, but that's not uncommon.
Even here, usually when you go to a doctor, there's an email, usually get an email with the phone number.
Yeah, there's this really cool new charting system that a couple of the doctors I see are using called My Chart, and I get downloaded the results of any lab tests that I've done, any x-rays, everything, not the doctor's chart notes, I don't see that, but any tests are all there for me to see, and if I have a message that I want to send to the doctor, I can do that and then usually get a response within a day. It's really pretty neat. But anyhow, I still haven't heard an answer to my question because the explanatory models are really important in terms of what's going on here.
I don't know, my observation is that when the patient tries to, provide his narratives, everything links together, right? So it is not just about weight gain or weight loss, but it's like linked to my everyday life experiences. My wife passed away, I couldn't sleep. Oh, my leg, got all this pain. So everything linked together. It's not like, and then, talks about, my feeling about what does greeting means, and then, what I observe, how other people in my community means. So from the patient's perspective, everything just linked together, and then it's not my responsibility to cut, everything, into different areas when
Yes.
I describe, the
Bio, psycho,
Right,
social.
right. It's really not my obligation. So when I provide my narratives, I just give you the whole thing. If you allow me to have this kind of space to provide my narratives, then this is how I describe, the whole issue that, surrounding around the issue of weight loss or weight gain or, weight management. But then if you look at the doctor's perspective, then it is really about, okay, what are the underlying reasons? This is the problem, and this should be the right treatment, but lack of compliance, what would be the reason that can account for those reasons? What are other background factors that can explain this kind of reasons? And then therefore we should pay attention to what other issues when I give you more health advice, and then even
So a very rational
right.
but compartmentalized way of thinking.
Right.
About what's the patient's explanatory model?
Actually, towards the end, I kind of think it became more consumerist in the sense that he began asking for medication. Like, I spent my time here, you looked at me, gave me my medication, I've given you my story, give me back my prescription. He was asking for quite specific.
Yeah, there's another remark
drugs.
that I didn't want to spend time getting to the end, but the doctor gives him a slip to say, come back in 3 months, we'll have another visit. And he says, why so long, doc? And so the doctor says, okay, 2 months. So yes, there is a bit of that.
I think
Although I wouldn't say this patient feels like they have the upper hand in this, but there is a bit of that.
I feel like I'm at a loss in the sense that it's not a typical fit in any of those bracket. It's not like a traditional, I have the power, because he's clearly listening and kind of trying to get to the narratives. But there isn't also this from the patient, a consumer, doctor, urologist, you are from, but then there isn't really truly collaborative, because the doctor hasn't moved away from what needs to be done and what he needs to prescribe and what need. So just feel like there's elements of everything, but there isn't, and so
It doesn't quite come together.
It doesn't come, so I don't know.
There's a little bit of that. I mean, in the beginning he was saying like, I can't be there all the time. He's admitting he's not, able to give all the answers. You have to take care of yourself at some point in time, work with me, kind of
And
thing.
I think the patient's not quite ready to take on that responsibility.
I'm thinking that some of the key elements, maybe key, maybe only time, that the doctors should have asked that didn't ask. For example, they lose weight, what kind of activities you have been engaged with, and then towards the latter part of the conversation, it goes, whatever you have been doing, just continue to do that. But then for me, I would ask what exactly have you been doing, what time, and then that kind of conversation, I think that should happen earlier in the conversation. And also this wife passing, I noticed that the doctor was kind of like stick with this fact.
Yes.
Although the patient says that, this pain and wake up at night happened before my wife passing. But then this doctor seems to have already recognized it as the cause of weight management or whatever. So he's constantly
Getting back to that.
get back to that. So I'm kind of thinking that it's true that the doctor wanted to find the real causes of the current condition of this patient, but then there's certain gaps. There were certain gaps that he needed to get the answers from the patient in order to fill it, to decide whether
Like,
it
what,
is
if you
actual
were
cause.
advising, if you were doing a videotape review, which is why we videotape this, in order to teach the resident, what would you advise? What are the gaps that you would try and point out to the resident?
Resident.
The doctor.
The doctor.
Uh-huh.
I would consider that in terms of stiffness, pain, obviously this doctor identified it as not the major stay of this
Yes.
visit.
Yes.
But if I was the doctor, I would just say that, okay, let's hear the story, or even more about the story, and then I'm going to, see what else we can do. But do not directly shut this off, saying that, we can do nothing about that. Or even if I, as the doctor, cannot do anything, I can refer you to some alternative treatment, like go to a Chinese doctor, get some massage, play some yoga or something like that. Yeah. So at least refer to something, channel it out,
Acknowledge it.
yeah, acknowledge it and accept it, and then channel it. If you cannot handle it, there's some way that some other people can handle it. So refer to some, do not just say this is a dead alley. We are not going to talk about it anymore. So I found that
Yeah,
that's
that's
I
good.
detected that as well. Like it felt like he was trying his best to empathize, but it felt uncomfortable. At least that's what I read from him, that it got a bit awkward, and you could see instances in his conversation where he tried to distance himself or tried to take that objective position again.
What would be an example of that?
Well, like at the end, maybe it's a slip, but we don't believe in slips in narratives,
Yeah.
but he was saying the wife's death, not your wife's death.
Yeah.
He was,
Or stay away from the table, chief.
yeah.
Did you get that?
Yeah.
That's not usually, language between doctor and patient, and he's a much younger man than the patient is.
He's trying, but
Also, often when I step into a room in a hospital, I feel that I'm in a field where I do not know the direction. I need constant direction from the doctor, as if I'm the student driver or something like that. And I really appreciate, when I and my wife went to, their check, and then they say that I'm going to put some jelly on your belly, so it's for the baby ultrasound. And then you say you might feel a little bit cool, but it's okay, and something like that. Then this doctor says, okay, I'm going to give you the prescription, but doesn't come to the conclusion now what kind of problem is that, and then so I don't think it's a nice way of guiding through, but it could just be me. I'm very critical.
So
of,
the patient might have needed more direct guidance
yes,
in how to achieve.
yeah, and conclusive remarks.
Well, what I found interesting was that even though he jumped on the diet and then he realized that his wife had died, he didn't sort of connect the wife's death to the diet. When actually he could have asked him and probed him a little bit more about whether his eating patterns have changed now that his wife, whom I presume was a primary provider in the home of
Food.
and how he was taking care of his own dietary needs now that his wife had passed away.
Yeah, I think that was probably because it kind of comes up coincidentally that the wife died. This isn't something that the patient brought to the conversation, but and that was a good question on behalf of the doctor. Who do you live with? What's happening at home? I mean, I think he was in his head thinking what could have accounted for this guy going off his diet. And then the patient volunteers, my wife passed. And I think probably the resident, the doctor was making that connection, but you're right that it doesn't get articulated. Okay, so there are certain topics that are out there, okay? Sarah, you wanna say something now?
Oh, it's
Yeah,
just
go
a
ahead.
little bit connected. I was really surprised the main thing that he didn't ask was specifically, I know he's not a nutritionist, but when he said, oh, everything I eat is probably fatty foods or something like that.
It's fattening.
Or it's fattening.
It's fattening.
Like, I was surprised he didn't say, okay, let's talk about some things you can eat, or what are some
More
things you can do to change, or why is it hard for you to stay on this diet? Is it that, like, one thing, if he's very involved with church and people are bringing meals over, which I assume is probably the case, you know, like, what is it that's changed? Is it in connection with his wife's death, or is it just his eating patterns that he is upset and so he's eating fatty foods, or he doesn't know what some good foods are to eat? So I was surprised you didn't explore and ask him, like, why is it difficult for you to stay on the diet, or what is your idea of what is something that you can eat to change?
Who's doing the cooking now?
Right. If he knows that food, if he identified in the beginning, okay, I can't help the leg, the diet or exercise is what I can do. I was surprised he didn't
Do
delve
more
more into
with
like
that.
some operational things he can do at the end.
Yeah.
I think it kind of became socio-psychological for the sake of socio-psychological, rather than pulling out stuff from there to feed into the biomedical part. Because finally, that's the takeaway I think the patient needs to take away from the interview. That these factors in my life are affecting my health in such and such a way, and this is how I can control that. Whether it is the stuff on the menu before or after the wife's death, or lack of sleep, or whatever. But like Sarah and some of us said, I think that connection is probably not as robust as it could
Yeah.
be.
Because I don't think any of us are convinced that the next time he comes back, he's gonna have lost weight.
Right.
So, as nice as this resident is, I'm sorry, I keep calling him a resident because he's a resident doctor, he's still in training. As nice as this doctor is, yeah, he's not as, this isn't as effective an interaction as we would hope. I do think there's so I think there's certain topics that are out there that they're both discussing, like we both understand each other. There's my legs hurt, and I'm stiff, ever since I had this operation. I need to lose weight. And by the way, my wife died. And there's something, and I think, I don't know where it is in the tape. I haven't watched this tape for a while. But at the end, but I think this isn't the first time it comes up in the conversation. And I don't know if you could make that out, but he's saying, I really want to be active. I want to be doing work. And the resident, and by the way, I'm not so sure this guy is big on church. That is something the doctor brings to it.
Yeah.
And I think, I know from my partner that I worked with, who taught behavioral science to these medical residents, that this is a religious doctor. So the patient says, everybody at church knew my wife and she was really active. That doesn't mean that he is, and so when he says, I want to do work and I want to be exercising, which I guess is hard for him, he's with a cane after his surgery, and the resident starts talking about, well, you can volunteer at church. I'm not too convinced that was this guy's thing.
Mm-hmm.
But there is another part that I'm sorry we didn't hear, and I'm not sure where it is on the tape, which is, Mary, you picked up that he said, "What? I'm feeling kind of crazy." He mentions that he's feeling a little crazy, and it doesn't really
He
get
says he
picked.
doesn't think the patient, the patient says, I think I'm going crazy. But the doctor says he doesn't.
Yeah, he doesn't really deal with that or pick up on that. And the word crazy comes up a second time where he complains about not working. This is a man who wants a job. He wants to be moving. He probably wants to get paid. I don't think he's looking to do volunteer work in the church. So there's that. So there's these topics where ostensibly they're talking about the same thing and they kind of understand each other. But if we were to prioritize what's important to each person, how would those priorities look? What would the patient prioritize first? What would be at the top of his list?
Discomfort,
His pain, okay? Did that get addressed? Okay. For the doctor, clearly it's weight loss. What would be the next priority after weight loss for you said is stiffness. I'm not sure that would be the next priority. Well,
Grief management?
grief management. I think that the doctor was very attentive to the fact that his wife died. And I think his pain and his discomfort would be at the bottom because the doctor says there's not much we can do about that. He says that right at the top. And in fact, how does the conversation begin? Can you remember back to the beginning? The patient sticking out his leg and he says it feels like it weighs 200 pounds and then really stiff. And immediately the doctor says, I don't know what we can do about that, but you've gained all this weight. So there's an immediate shift in the conversation to what the doctor feels. And to be fair, that's what he feels like he can do something about, but he Mishlered him. He totally cut off that part. And then when I've been kind of hammering away at this side of the table about what's the explanatory model, and you may not have been able to understand or hear that very well, but I think that the patient has a very elaborate explanatory model that I don't quite understand, but it has something to do with electricity. I feel shocky, I feel nervy, and I can't touch water, and I can't stand wool. And they hooked me up to these machines that went, and ever since then, their electricity went through me. And they're saying, I think he has a pretty elaborate kind of idea of what's wrong, and it may or may not be right, but it doesn't get acknowledged very well. And I think until that gets acknowledged, I'm not sure they're going to make much headway on the diet thing. He agrees with the doctor that he needs to lose weight. He likes this doctor. He wants to come back in 2 months rather than 3 months. So there's a lot of positive things going on, but I think you all have picked up on it. This change isn't going to happen until certain things happen, that you get more explicit about the foods, that you find out who's cooking in the house, but also that you pay some attention to the main reason this patient came. He didn't come in for losing weight. He came in because the pain.
So can we say that the explanatory model for the doctor is problem, solution, except that this problem is defined by the doctor, who's just so obsessed with weight loss? You know what I mean? It's problem solution, but it's problem the way I see it to be. The doctor sees it to be.
Yes. And I mean, we go to doctors to get their expert opinion. I don't think this doctor is way off the, this man does need to lose weight, and it may have something to do with the pain in his legs that he's carrying this much weight. So it's not that the doctor is wrong, but is it collaborative?
Yeah.
It kind of has a veneer of collaboration, but not really an engagement in a way that might be more effective.
it just, sorry, it made me think when you were, when you were explaining just now, doing a health comm project and you go into a rural context and say, okay, clean drinking water, boil your water, and then they tell you, fix my road first. And then you don't see the connection, but actually it's the road that prevents them maybe to get to that place. And I just feel like this is what's happening. I have a, and if this is what you need to do to fix it, but then to get there, it's like, they're not, maybe losing that weight unless what he thinks is the issue is actually addressed. And which is the pain and the, the electricity or however he was
And I
describing
think Tom is right that this doctor doesn't have the capacity to change that, but to acknowledge it and maybe make a referral. He says, did you talk to the neurosurgeons about that? And the patient says, well, I meant to, but I didn't, what I said about question asking. So maybe this doctor could be his advocate and make that link for him. Because I just don't think there's going to be any change until that happens.
But
So,
there are power issues in that, right? Because he's more like a general practitioner, and then for him to refer the patients to a neurosurgeon with what seems to be the patient's neurosis about his condition, the doctor might think, I probably shouldn't do that. He'll probably err on the side of caution.
I don't know. I mean, that's hypothesizing
Yeah,
a lot.
yeah.
I don't know about that, but I think, so you're saying because he's a family doctor, he doesn't have the power to get to the neurosurgeon?
Or he doesn't feel that the condition necessarily warrants attention.
Well,
by
I
the
think that's
neurosurgeon.
more the issue,
Yeah.
that he doesn't feel it warrants it, but, just saying to the patient, did you talk to the neurosurgeon about that? He might have to facilitate that. The family doctor is supposed to be the coordinator, he's your primary care, he's supposed to be the coordinator of your care. It doesn't always work that way, but I think not giving any credence, I mean, you called it a neurosis. I don't know that it's a neurosis. He has pain. I mean, maybe acupuncture would help with that, or something, or massage or something. The Western trained doctors are not apt to be thinking that way, but not to acknowledge it at all, or to write it off as if you're saying it's a neurosis, you're saying there's not really something there and you're being...
Well, that was the feeling that I was getting from the doctor, because also partly the kind of language that the patient was using, like,
Okay, so that's not your judgment,
Yeah,
you
no.
think the doctor was making that judgment?
Yeah, that's right.
So my question is, and kind of wrapping this up, is if you were the communication specialist in this situation, reviewing the tape, we heard from Kung what his advice would be. Is there any other piece of advice you'd want to tell this doctor in training?
I feel like saying, don't ask if you're not really want to listen. I feel like he's asking because there's this training of biosocial included, but he's so nice, and let's move past the fact that he's nice and he's giving this time and he's listening. But I really felt like he's stuck in this critical listening mode where he's listening for certain things and he's not really listening to the patient. So one, you have to listen, and two, don't ask if you don't want to really, if you're going to brush it. It's a frustrating conversation. For me, I just didn't feel like it really achieved a purpose.
All the time that was spent.
All the time that was spent.
What else?
I think it's the same thing I said before, that the social psychology has to feed back into the biomedical, so that he could have asked or looked for specific reasons in the man's context that he could have then tied back. That could have made the entire interview more holistic, more comprehensive, and I think therefore more effective.
And I'm sorry, your name is?
Leah.
Leah. So you were the one that said, well, in the patient's story, it all linked together. So how would you get the doctor to recognize those linkages? Because that's what really you're talking about.
I thought I just have an idea with it, so you have a
Are there questions that the doctor could ask that would make that a more coherent story?
I think if he had probably focused a little more, I think he was on the right track. For instance, when he said my wife passed away, I think he did say something to the effect of food. I don't remember, but if he had continued on that track and said, oh, so who used to cook at home and now he does?
Yeah.
And if he had gone that track,
So probe more lah, probe lah.
with the eye on identifying factors that can affect what the man has come there for. I mean, which comes back to what's the objective of this whole interview, right? So ask questions that will give him insights from the broader context, but which can inform what the objective of the whole meeting is about, so that it becomes more productive.
Now I remember what I want to say because I suddenly I think it's good that the doctor really shows some support. I think that's sometimes the patient wants that. Okay, at least the doctor shows some support, understand those difficult moment in my life. So maybe that would be something being appreciated by the patient, and also the patients that the doctor has, right? But the other interesting thing that I was thinking about is that anyway the doctor will have this predetermined agenda there that is about weight management. So there's like an interesting thing I was thinking about when Ganga was talking. I was like, okay, what would happen if that he still work around the predetermined agenda that he want to achieve? That the whole weight management issue. That okay, I will still try to persuade the patients. By all means, that I would try to let the patients to know the importance of weight management, and then I would try all kinds of approaches to persuade the patient, right? Because from my perspective, although I want to be supportive, but I do have my profession that this is my position, and then I really need to stand on my ground and then to do whatever that I can do. So that would be like the standpoint that we really need to hold. So then it would more about the strategies, the communication strategies, and that he can apply to kind of persuade the patients. So I was thinking about, okay, so from the doctor's perspective, it has to be like that or not. So I was thinking about that one.
Okay.
Asking the question.
Oh, I think persuasion is in there, but I think there's some other things that if we go back to the difference between disease and illness, I think we're seeing that played out here. The patient's experience versus what the doctor knows to be a problem. Do you think they, in Hated and Paternitty's terms, was this taking a history or was it building one?
I think it was more like building a story than building history.
Oh, what's the distinction you're making?
Because he asked about the story and he got a life story, but by history I mean more related to the topic at hand. So he opened up the floor and the story flowed out.
But what is the topic at hand? See,
Yeah,
that's what's
which again
that's
have two
what's
different things.
contested. Yeah, yeah. So I think he was attempting. I think he really was attempting to build one with the patient, but in the end, I don't think there was a coherent narrative that was really co-constructed. They were kind of parallel and not coming together.
It made me think about there was an article which talks about how easily we can change the direction of the conversation by simply asking a question, right? But then that doesn't necessarily mean that is what is important to the person communicating to us, and that's what I felt
We're
like.
trying to do our agenda just like the doctor was. So that's a good segue. Let's take a little bit of a break and come back and let's talk about your field experiences with interviewing and what Reisman says about that. Pretty well, and gave you a lot of examples from her own work in India about the different things that the interviewer brings to field research that can make a difference in the data, really. And certainly how, in the meaning of the data, okay? Including even transcriptions, certainly translations, which is always problematic. So I was interested in hearing some of the experiences that you all are having with your own field research, and if you had if you had some episodes in which you feel like either you that you just want to share with us, or if you'd like some advice on what's happening, and you had your hand up already, right? Yeah.
Actually, I and HRV did a study about the integrated medicine, how, elderly Chinese Singaporean women here, they use both TCM and the biomedicine to, maintain their well-being. And then when we analyze the data, we did, find some quotes, like they would tell us that, okay, these patients and this woman, they do perceive, tensions that occur at multiple levels. Like they observe the conflicts between the biomedical system and the traditional Chinese medical system. They know that there exists some differences here. And then they know that, usually the Western physicians wouldn't have any dialogue with the Chinese, practitioners. And then they also know that there is like a generation gap between themselves and their younger family members. So the data are very fascinating. But then when, we as a researcher, when we come to our conclusion, and then, based on the findings that we found, and then, participants are very frank. They told us that, okay, we try to explain, our use of TCM to the Western physician, but they would just tell us that, okay, you shouldn't do this, you shouldn't do that. The Chinese medicine is going to kill you, and then they don't know the side effect, right? So according to the quotes, they would tell us that, okay, why bother? Because even if we do tell the Western physicians that we are going to use Chinese medicine to attune our body, this is what they are going to tell us. And then some of them tried, some of them they didn't. And then actually they are facing some very serious illness. For example, some women, most of the women, they will have their direct family members died, because of cancer. So one particular quote from one lady, her husband, had lung cancer, and so he went to, chemo, and then, they try to explain to the Western physician that, okay, after the chemo, we are going to use TCM to attune his body. And then of course, they did, tell the Western physician that's what they are going to do. And of course, that the doctor would, respond pretty, strongly to say, now, okay, you shouldn't do that because, it's not good. So, and then, but then in the interview, they say, yeah, but my husband really didn't feel well. So after we told the Western physician, we just went to the Chinese, practitioner, and then we just, asked help from the TCM doctor. And then after that, I don't know what the side effect would be, but obviously my husband feels better, so we guess, it's effective. And then, when, during the interview, of course we will probe and then say that, okay, what would the Chinese physician, the TCM physician would say? And then they say, oh, of course we wouldn't pass the Western physician's message to the Chinese doctor, because we know what the Chinese doctor would say. He would say, yeah, oh yeah, those Western physicians, they are so smart, so they will kill both the good cells and the bad cells. So they are so clever, so they are just going to kill everything, right? So and then they say, why bother? Because we do not want to get involved in this kind of debate that ourselves couldn't handle. So That's whatever, that they're
Who
doing.
said that?
The patient.
The patient
The
said
patient,
that,
we
okay.
don't want to get into
Okay.
get into that kind of debate.
Uh-huh.
So, we will just do whatever we think.
So what is the problem for the researcher
For the
then?
researcher is that, okay, so now we observe this kind of tensions here, and then we see that, okay, women here, they do have enjoying some kind of autonomy in the decision-making process. But then we also saw this kind of blind spot when they use the so-called, integrated medicine. But then, okay, so now we have to come to our conclusion part in our research paper, and then we want to provide some practical suggestions because we still want our research to have some contribution, right? But then, okay, I found that it would be a little bit naive for me as a communication researcher to say, okay, we suggest that the physicians should have more dialogue with the patient, they should engage the patients more. And I feel like, okay, this kind of, conclusion is a little bit, just naive because from the communication, researcher's perspective, it's really not this kind of suggestions is just like, okay, you just do that for lip service. Okay, everybody should talk more. But when we really, see the data and then they will just tell you that. But that kind of conflict exists between, the practitioners from two camps. Then for what's the role for researchers in this kind of, phenomenon, then, I really couldn't say, okay, all of you, doctors, you should talk to each other. Because that's not the thing that I don't think, if I have that kind of skill, then
Well, I mean, I can't tell you what to do either, but I would go back to what was your original research questions? What was it that you were collecting these narratives to answer what questions?
Originally, we want to find out, it's more about, find out and then to describe, to understand more about the phenomenon here. And then we will have this kind of presumption. We thought that, okay, for this, because we try to find those women with, low income and low educational level, and then see how would they navigate between these two systems and then see,
Which it sounds like you did.
Right.
So you're answering your research question.
Right.
To the degree that you get into recommendations, or I would call them implications of what you're doing, I think it depends on where you plan to publish that and who you're addressing. So if it went into a healthcare journal, sometimes they specify that they want you to have practical implications. I don't know if this is a widely read journal here, but there's a journal that does publish a fair amount of qualitative work called Patient Education and Counseling, and they're very interested in communication kinds of issues. And part of what that journal stipulates is that every article that is published in there has to have not a big section, but a section at the end called implications, like practical implications. And if you were writing in a journal like that and you were addressing people who are in practice, then I think a recommendation or not necessarily a recommendation, but an implication that it might be more effective if Western doctors specifically asked what patients were doing, or vice versa, the traditional Chinese medicine, that it would be in keeping with what the intent of that journal is. For a communication journal, probably not, because you're not talking to clinicians. So that would be
There's a
my...
hope that your data can really have some kind of contribution to help the reality, but sometimes just feel okay, a little bit frustrated because after you reveal the phenomenon, then how can you move one step further to help?
Yeah, so, again, it depends on who it is you want to share your information with, your study with, and I think if it's with clinicians, then that's appropriate. I'm curious as to, since we're talking about narrative, what your successes have been in collecting stories. And I ask that question because I often see this with my graduate students where they're doing qualitative work and they're asking open-ended questions, but they're not asking questions in a way that encourages people to really tell you their stories. Instead, they get a lot of kind of more abstract generalization kinds of things. Decontextualized. And so then we have to go back and really see how they're asking those questions. So, or even how they have framed their research questions to begin with. But so I'm wondering about what your experiences have been and if you feel like you've been pretty successful in eliciting narrative kind of data that you can work with. It sounds like in your study, there is that.
I think when I did my dissertation, which was on corporate social responsibility, one of my questions was to find out how senior leaders and business managers articulate their understanding of CSR in the Indian context. And so my opening question was usually very, very general. I just asked, what according to you is CSR in the Indian context? I am not looking for a definition, please explore it aloud. But interestingly, I got beautiful long answers. Like usually this question would give me about 40 minutes of reply.
Wow. That's great.
Yeah, and then I would have to mentally run through, make sure that, because most of my remaining questions would have already been answered. But there was one particular interview, he was the CEO, he was the founder, and I think the setting helped. He was not in his headquarters, he was traveling and he happened to be in the city I was in. And we were in the lobby in a cafe in the hotel we were staying, totally relaxed, no secretaries, no deadlines, no nothing. He gave me 1.5 hours, and that was completely beautiful storytelling. So when I said this, he said, you know what? He reminded me of my uncle who often tells stories. He said, you know what? One day I was driving along when I saw this board, something for the elderly, and I thought, who in this age is interested in the elderly? And I stopped and I asked, meanwhile, I'm getting a panic attack because I'm not sure where this is going, right? And I don't know whether I'm getting the responses to my questions, but of course I can't stop him. And I don't want to stop also because it's a beautiful story. And then he talks about how he set up this foundation which trains underprivileged people. And then when he went to a hotel, how this guy came up to him and said, sir, do you remember me? So there's a lot of stuff coming out through his narratives, but it wasn't easy for me to put it in what is CSR, why CSR, benefits of CSR, in the boxes.
So you're kind of like in the position of the physician who has some things they've got to get to, and this guy is a storyteller, but kind of you're thinking off topic. And yeah, go ahead.
I was say I guess I take the opposite position, and then why I probably find that interview frustrating is because I have my research question, but whenever I go to an interview, I never go in with an objective to get a certain response. It really is about whatever comes out of it. So I never feel like I'm tied to my questions in any way. But it's in the back of my mind, right? This is some things I would like to find out about. But if it doesn't come up, I'm okay with that too, because I allow myself that flexibility. But all the while I'm thinking, does this really get back to my bigger question, right? As opposed to the little question. And so this is why I think because I take that perspective when I am doing the interviews, it was also sort of hard to see that kind of a interaction where I felt like there's an agenda to meet, there's an agenda to meet, and we're not meeting that.
I think it's really a tension between flexibility and You want to have some degree of control. I mean, you're there for a reason. But also, I mean, in the end, did you feel like the story he told you in his mind connected in some way?
Of course, absolutely. It was a beautiful, holistic narrative from beginning to end, and it ended up with his own system. Really, and it ended up with. It was a whole string of stories. So the end was something like he met the chief minister of a state, who told his son something to the effect of so many stories, right? You know, look at this man who's done whatever wonderful stuff. And so that was kind of the end, the rewards part of what he got out of it. Also, when commenting on conspicuous consumption in the corporate sector, everything came out through little stories, which was great. But I've always thought, this is something I want to ask you. Now, like you explored Gina's narratives, I think this person's narrative requires a focused narrative analysis on its own, because I was trying to draw themes across participants' narratives, right?
Okay.
And I found that challenging. When I'm trying to draw themes, I found this person's particularly challenging to tap on, I mean, in terms of trying to find common themes. So this person's kind of really stood out. All the others, I could draw some kind of common themes, whether it is nation building or paternalistic notions of CSR or whatever. Yeah, he did tap into paternalistic, but his kind of really stood out, and it challenged me in the sense that I couldn't just draw across, but when I saw you doing the Gina narrative one, that made a lot of sense, because this one, I think, calls out for that kind of analysis.
And it I mean, with Gina, it still contributed to a more general
Yes.
model.
Yes.
So I think you do have to give yourself the freedom. So if you're looking for categories across, you're doing grounded theory, right?
Yeah.
Which is great in itself. Reisman makes the distinction, she has a whole chapter on thematic narrative analysis, and she compares it with grounded theory, and she said, well, the difference is though that you keep the boundaries of the story. So it's different than grounded theory because you're not, trying to cross all those. But does that mean, and so with this particular respondent, it may be worthwhile just to do a very intensive analysis of what he was telling you and then what bearing it has on the corporate issues. There's also research like Isha is doing where she is doing kind of life histories, but she has 35 of them. But does that mean she has to do grounded theory? She might be doing grounded theory, but she could also do narrative, but then what she's probably going to do is to create a typology of stories from her 35 that she's hearing among her population, this genre of story and this genre of story. And we'll see that we're going to start reading Arthur Frank in the next 2 weeks, and that's what he's doing. So he looked at many different individual stories of illness, which is what he's interested in, but then he saw that there were kind of meta-narratives that these individual things fit in. So it's not the same as grounded theory where you're just crossing, you leave behind the stories to get a list of categories from which to theorize. And by the way, that's what people often forget with grounded theory, is that there's a theory part to it. A lot of people come up with this big list of categories, but what does that mean? So if you're doing grounded theory, make sure you use it to really theorize when you're done. If you're doing narrative, we also want to theorize. And it's possible to do 1 or 2 or 3 individuals and get a ton out of it, like I hope I did with Gina. But I think it's also possible to to come up with these sort of meta-narrative kind of categories. That these kind of stories share these characteristics.
I can definitely see the potential for this study that I did, and each one was involved on the media use of juvenile delinquents and youths at risk. So we went to like rehabilitation homes where these boys were being held, and then first we spoke to the social workers, the counselors who knew their case histories, and then after that we spoke to the boys themselves. In terms of actually eliciting as much as we would have liked from the boys, I think it was difficult because they clearly had troubled pasts and they weren't necessarily willing to confront their past to the extent that we wanted to probe. And we also didn't want to be
And with
too
women interviewers.
Exactly. That's right. We did have a man on the team. But there were also issues of ethics, right? Because to get it past the IRB was a job and a half because they were really worried about the fact that this was a population that was quite vulnerable and so on. And so we had to have various kinds of questions toned down significantly.
So if there was anything that they revealed, we couldn't ask anything new because we had recorded and kind of put us in a position where we felt like, well, what promise of confidentiality, and we turned around and
Right.
That's right.
Yeah, the ethical issues when you're asking about things that are very personal or that could actually get somebody in trouble. Yeah, so there's accommodations that need to be made.
change our direction.
Yes,
Yeah.
but I do see a lot of potential for us to look at some of the cases in using the narrative approach, and also you can see meta-narratives across the cases.
Yes, yeah, and that way you don't have to implicate an individual.
Yeah.
What I did, and then this is the piece that we were talking about, is also that, and some of the things that she said really struck me because I'm always challenged by my position when we're doing that, to what extent can I be an objective researcher and have this purpose, but to what extent do I bring myself to be part of that. So for this project, it was completely about me as much as it was about the participants.
Why don't you give some specifics on that?
So I ended up writing a piece where it really is a story about both of us, right? In terms of how we tell stories about the same culture that you come from, but different interpretations because of what you have or don't have, or where you are in life. So it really, and then when the first thing she says here in terms of the researcher does not find narratives, but instead participates in their creation, is I think the position I was taking is that I'm there to kind of create this, but in creating that, I am just as equally a participant as are my participants. So this is why it was easy for me to perhaps say, well, my agenda is just to understand and know who they are and why they've come to be, in a certain way, or how they understand that to be. So I wasn't really tied to in answering a certain kind of question, because it really was about this idea that we could, and then. So now as I'm writing it's really a fun for me too, because I get to really put myself in my research, and this has been the by far the funnest paper I have ever, because I feel like I can say it. I can say what I'm thinking. I can say where I'm coming from. I can put myself in the research. I don't have to remove myself in the narrative. I can tell you how I understand the narrative, and from my perspective, and so. So it's really, I don't know if anybody else would think it's fun, but I certainly have fun writing it in that sense, because I really feel like how I was listening and what I was asking, or what I walked into the room, gave me a different set of interviews, or different sort of life stories, because I may be listening for certain things, or I see a certain thing, or I ask a certain question, or I say, oh, but Mike's, kind of have a conversation in return, as opposed to a question saying, oh, really, but, oh, that's really, I don't understand that, because this is really something that I've never seen, right? To kind of respond, and putting my response out there in terms of can you help me understand this as well? So it was very different way of doing an interview than I did for my dissertation, which was very much like it was a grounded theory, so I had to have my, think about my themes and my questions are very, very different in terms of any kind of narrative research that I have done so far, which always, you do think about your questions.
I want to respond to what you're saying. Mary, do you need to go?
Yeah, I need to go, but
Let
I'm
me
really
just- Let me
really
just
want to
say
listen
something
to.
about the assignment for next time, and then I'm gonna come back and respond to each. Next time we're doing performative, we're doing narrative as performance, are we not? Am I wrong?
Are doing, yeah,
Yes.
narrative performance.
Yeah, so we're doing narrative research as performance next time, and so you're gonna see somebody perform the research, and so, sorry, that's my text thing responding to me. So what I did is give you, this is somebody who had been a doctoral student with me. I've assigned the chapter in which she wrote her data as grounded theory, okay? So you can see kind of a more typical writing of what she's talking about. She did interviews with like 25 women who are considered obese or overweight, and their experiences in general and specifically with the healthcare system. Then what we're gonna see in class is her taking the same data and performing it. And when you see it, you'll know what I'm talking about. But I just wanted to explain why her dissertation chapter is there. And again, you don't have to read every detail, it's just to get the comparison in the way the data is presented. Second is we're gonna start reading Arthur Frank, who has this typology of illness stories. So, and Bonnie, the woman who performs, will make reference to Arthur Frank, so it kind of fits together. We're reading 2 of his chapters for tomorrow and 2 for the next time. So that's all I wanted to say before Mary left us.
And can
yeah.
I just add, the
Yeah.
thing that in her article, I think from everything that she said, the thing that struck me the most in terms of, I think, my experience, regardless, not only in this project, but in the other narrative stories that I've done, is when she says the specific wording of the question is less important than the interviewer's emotional attentiveness and engagement and the degree of reciprocity in the conversation. And that, to me, in some ways, encapsulates how I think of narrative interviews, regardless of, because it cannot always be free in getting in interviews and in stories. Sometimes it is more structured, but I think, to me, that was really what I think of when I think of narrative.
Yes, that's a very important statement. I think also what you said, Isha, about positionality. I mean, does anybody believe really they're an objective researcher? Does that exist? I mean, you're people, you bring your personhood into your research, and for the students that I work with that are doing any kind of qualitative research, whether it's narrative or not, and I don't know what I would say if I taught, more positivist, statistical kind of, I think I might still say the same thing, but I know it's not done. But in qualitative research, positionality, accounting for who you are and what you're bringing to your research is, I think, critical, because it's going to shape your whole interpretation of it. We're doing interpretive research, and so if you don't account for that, I think you're really being remiss, actually. So not only in this piece that you did, although this is more about your direct response with your respondents. Yeah.
For me, it also mattered a lot in the recruitment.
I'm dealing with in vitro fertilization, Singapore women who are going for in vitro fertilization. So it mattered a lot to them that I said that I also had experience with in vitro fertilization back in San Francisco. And so the women who said yes to me were the women who were curious about that, or that I also have an adopted son. Or so for the women who were successful, they were interested about that. And then when I was in the interview with them, I started to highlight the differences between us so that they'd be more patient in explaining, like, oh, this is Singapore health system, so I'm not from here. And then they would go into detail about the complementary.
Sort of take you under their wing.
Right,
Yes.
right. But at first, it's really, my recruitment letter is really emphasizing the sameness between us, and that I'm also participating in the forums that they also participated in, and I could also cite the stories that they were reading.
And that helped with your recruitment.
It helped a lot though. I still had a very high rejection rate, but the women who said yes were curious about the similarities that we might have had.
I thought I would read you just, I don't know, it kind of tickles me. I don't know if it will tickle you or not, but this is one of my doctoral students from her dissertation who did ethnography. She's Indian, she's from Bangalore, and she was looking at food insecurity in one of the big slums in Bangalore. And for her first at least month or maybe month and a half, she would go from her parents' home and walk to the slum, and she was trying to make inroads with the people there, and she was feeling kind of frustrated, and she knew she wasn't doing very well. So in her dissertation, she wrote a part called Confessions of an Ethnographer, and she talked about the real problems that she had and how things worked out. And this one is my favorite. She says, Mom accompanied me to the slum today. Yesterday I was feeling a bit down. I'm making little progress connecting with people. They answer questions and they talk to me when spoken to only. When I walk past their homes, they acknowledge my presence. However, there is something missing. I'm not going to be able to collect data if it continues like this. So she's really worried about her data collection. I took Mom to the field and introduced her as my colleague. I think they bought it. I told Solomon, who was her research, so it was like a research assistant, to take the day off and catch up on his field notes. I was worried when Mom stepped foot into the slum. I told her to wear a simple sari and not call attention to herself. She did not listen. She actually wore a beautiful turquoise blue sari. It looked like it was raw silk, but it wasn't. I always made sure I wore a simple salwar, which is kind of like a tunic thing, right? Mm-hmm. I have seen other women wear salwars like mine, but Mom didn't want to do that. I didn't want to argue, so I let her come wearing that sari and her overpowering rose perfume. I wanted to see if there was something I can do better to connect with women. She has volunteered in slums before. In her free time, she teaches children at a government hospital. She has a good understanding of the type of people I am meeting with. Before leaving, I show her the interview guide, and I told her what I would be talking about. We were to focus on what they liked and disliked about their community. This is a very general topic. She agreed to sit quietly and listen and watch. I could tell she was not too enthusiastic about coming and didn't think she could help. Nalini saw us entering the slum. I waved and she waved back. We walked her home. She immediately asked my mom who she was. My mom replied, I work for her. She is going to teach me something. I then asked Nalini if I could talk with her while she was washing her dishes. She agreed. Mom and I both sat on the dusty piles of brick. I could tell Mom was itching to talk. Before she could say anything, I started to shoot questions to Nalini. I asked her, what do you like about living in this community? She looked up, laughed, and replied, I don't know what to say. I didn't say anything for a few seconds to give her some time to think. I then filled the silence. There must be something you like here, right? Nalini continued to wash her dishes. She kept scrubbing her dishes. The bottom of the pressure cooker that she was scrubbing was looking black and worn out from extensive cooking. Everyone was silent. Mom then opened her mouth and told Nalini, you know, even my pressure cooker has those black stains. Someone told me when you pressure cook, if you put the thick skin of a lemon or lime, it will not go black. You can even use it for cooking and then put the used lemon. It can even reverse the stain. You try it. Nalini stops scrubbing, looks at my mom and says, oh, is that so? My God, I waste so much time scrubbing this. I will do it from next time. Mom was not supposed to talk. Still, she immediately changed the topic and proceeded to talk about the neem tree. Nalini was growing a neem tree next to her house. Is that a neem tree? It's so good. What do you use it for? Neem is so good. Can I have some leaves from the lower branches? I was starting to get annoyed, but I couldn't get Mom to look at me. She was engrossed in the conversation. They were talking about making neem face packs to improve their complexions and grinding the leaves for cleaning their bodies. It was almost like a competitive event. Nalini would share how she used neem and my mom would add to the list. The conversation on neem ended with my mom saying how neem can be used as a natural deworming medicine. Nalini excitedly said, oh really, you know, we have so many worms in our water. When my child was newborn, we used to buy Bisleri water from the market. Now I just strain this water and drink. I think I will start giving them neem leaves for the worms. I thought Mom would start realizing she had completely deviated from the plan. Nalini's young son came out of the tin shed. He was wearing his school uniform. I could tell he was getting ready to school. My mom called him towards her. Nalini smiled and told her, go to Auntie. He then looks at Mom and says, she then looks at Mom and says, can you please tell him to study better? We spend so much money sending him to school. He does not study well, always roaming and playing. Mom looks at her son, Rabi, and with a stern voice she tells him, why are you doing that? Why are you troubling your mother? Is what your mother saying true? Are you going to continue being a bad student? She then looked at Nalini and said, listen, if he continues this behavior, don't send him to school. Let him not go to school. Let him stay at home while all his friends go to school. They will learn and they will progress. Nalini then adds, you are right. I'll stop his school after this month and won't pay the fees next month. Robbie looked petrified. He went back into the tin shed and got his bag. Within a few minutes, he put his shoes on and left for school. Just as he was running away, Nalini said, if I hear one complaint today, I will stop your school.